Welcome to Pain Policy Practice. Friends, I apologize for a longer break this time between my videos. I had to take care of some pressing needs. And this channel is certainly alive with a lot more content pertaining to healthcare delivery, administration, regulation, and business of medicine. So in today's pain management discussion, I will be focusing on a topic every opioid prescriber needs to understand clearly, and that is opioid use disorder, identification and treatment, including MAT and key red flags. When patients are receiving opioid therapy for chronic pain, the clinical question is not only, is the pain controlled? It is also, is this treatment still safe and effective? Is the function improving? Are there any warning signs that opioid use is becoming harmful? So today we will be talking about how to identify opioid use disorder, how to recognize red flags early, and how to transition from risk recognition to evidence-based treatment using medications for opioid use disorder, or MOUD. Now, this includes understanding when medication-assisted treatment, or MAT, may be appropriate for opioid use disorder and when referral or coordinated care is needed. By the end of this discussion, you should be able to answer 5 questions. Number 1, when should pain providers suspect OUD? How do we separate dependence, tolerance, misuse, diversion, and OUD? Third, which red flags require deeper evaluation? 4, when is buprenorphine, methadone, or naltrexone appropriate? And 5, how should providers document and refer? Pain management providers are often at the front line of opioid risk detection. So we often see patients with lumbar radiculopathy, failed back surgery syndrome, complex regional pain syndrome, neuropathy, cancer-related pain, osteoarthritis, spine disease, and long-term opioid exposure. Some patients are stable and appropriate candidates for carefully monitored therapy, while others are struggling with sedation, escalation, opioid-induced hyperalgesia, benzodiazepine co-use, early refills, abnormal urine drug tests, or functional decline. OUD may appear as early refill requests, dose escalation, lost prescriptions, abnormal drug tests, multiple prescribers, functional decline, withdrawal-driven use, sedation, or overdose risk. Now, the clinical challenge is that OUD can hide inside routine pain care, and we may not even recognize it at the onset. The goal is not to catch patients, but the goal is to identify risk, diagnose accurately, reduce harm, and offer treatment. So MAT versus MOUD. You will still hear the term MAT, or medication-assisted treatment. Many clinicians or insurance payers and patients are familiar with that term. However, the preferred terminology in many professional circles is now MOUD, which stands for Medications for Opioid Use Disorder. So why does that matter? Because the medication is not merely assisting treatment. For many patients, medication is the treatment foundation. OUD is not diagnosed by one data point, one drug test, high opioid dose alone, or physical dependence alone, or tolerance alone, patient frustration alone, but rather it is a pattern of impaired control, risky use, craving, and continued use despite harm. So for pain management providers, here's the nuance. Tolerance and withdrawal alone do not automatically indicate OUD when a patient is taking opioids as prescribed under medical supervision. Opioid use disorder identification and treatment. How do we do it? Opioid use disorder identification includes identification of red flags, understanding when opioid therapy is no longer functioning as safe pain care, and knowing when medication-assisted treatment, or more specifically, medications for opioid use disorder should become part of the clinical response. So here's a key point. Opioid use disorder is not simply bad behavior, and it is not the same as physical dependence or tolerance. We are looking for loss of control. We look for compulsive use. We look for continued use despite harm. We look for cravings. We look for inability to cut down. We look for opioids becoming central to patient's life in a way that damages function, safety, relationships, employment, or even medical care. A patient can be physically dependent on opioids without having OUD. Yes. A patient can develop tolerance without having OUD. But when opioid use becomes compulsive, harmful, difficult to control, and continues despite consequences, we must shift our clinical lens from opioid compliance to diagnosis, safety, treatment, and recovery. So when documenting opioid risk, language matters. Instead of labeling a patient as drug-seeking, non-compliant, or having a dirty urine, use objective clinical language, friends. Document the behavior, the toxicology result, and the safety concern. Now, this shift reduces stigma, improves clinical accuracy, and makes us better providers. In chronic pain care, opioid use disorder can be difficult to identify at the outset. Patients may have legitimate pain generators. They may have prior surgery, degenerative disease of the spine, or neuropathic pain or trauma, functional decline, sleep disruption, anxiety, depression making pain worse, and years of opioid exposure. So the clinical question is not simply, does this patient have pain? The patient definitely has pain. But the better questions are, is the opioid therapy helping the patient? Is the function improving? Is the patient becoming safer or less safe over time? Is the medication being used as prescribed? Are there signs of loss of control? Are there signs of harm? And if opioid use disorder is present, how do we respond without abandoning the patient? That is the heart of this topic. OUD identification is not separate from pain management. It is part of safe pain management. OUD concepts, including identification, principles of management, are all grounded in several major clinical and policy frameworks. The CDC 2022 opioid prescribing guidelines emphasize individualized care, risk assessment, avoiding abrupt discontinuation, and arranging evidence-based treatment when opioid use disorder is identified. SAMHSA Tip 63 reviews the use of FDA-approved medications for opioid use disorder, including buprenorphine, methadone, and naltrexone, along with recovery support strategies. ASAM Guidance supports comprehensive assessment and evidence-based treatment for opioid use disorder. PCSS MOUD provides provider training, mentoring, and clinical education to improve prevention, identification, and treatment of OUD across settings, including pain management. And finally, Medicare LCD, Local Coverage Determination L39849, provides an operational coverage framework for opioid treatment programs, including requirements around diagnosis, assessment, informed consent, treatment planning, overdose prevention, naloxone, drug testing, and covered provider types. So this is not just theory. This is where clinical judgment meets real-world provider responsibility. Now, dependence, tolerance, misuse, diversion, and OUD. This is one of the most important sections in OUD for pain clinicians. Physical dependence means that stopping opioids abruptly may cause withdrawal. Now, this can occur with long-term prescribed opioid therapy and does not equal addiction. Tolerance, on the other hand, means the body adapts and the same dose may produce less effect over time. Again, tolerance alone is not OUD, friends. Very important. Misuse means the patient is using medication in a way other than prescribed. Misuse can definitely be dangerous, but it still requires careful assessment. Now, diversion means medication is being transferred to someone else. Diversion is a very serious safety and legal concern. But even then, we must assess the patient's own use, safety, and treatment needs. Opioid use disorder is a pattern of opioid use with impaired control. Continued use despite harm, craving, and risky use and functional consequences, as I mentioned. Now let's start with the most important principle. Opioid use disorder is a clinical diagnosis and is definitely not a character judgment. It is not a label to apply casually to our patients. And it's not the same thing as physical dependence. And it is not the same thing as tolerance or having tolerance alone, which does not mean that a patient has opioid use disorder. Now, this distinction matters because there are many patients on long-term opioid therapy who will develop physical dependence. Now, that means abrupt discontinuation may produce withdrawal symptoms. So that alone, being physically dependent on opioids alone, does not mean that the patient has opioid use disorder. Many patients may also develop tolerance. As I mentioned, that means the same dose producing less effect over time. Now, that alone does not mean opioid use disorder either, right? So the concern rises when opioid use is associated with impaired control, compulsive use, craving, continued use despite harm, unsafe use, or clinically significant impairment. Now, that is where providers need to widen the lens and look at it more clearly and more deeper. So for providers, language matters. Tolerance means reduced effect over time at the same dose, as I already mentioned. Physical dependence means withdrawal may occur if the medication is stopped abruptly. Misuse means the medication is being used differently than prescribed. And that may include taking extra doses, using someone else's medication, or even combining opioids with alcohol or sedatives, or taking opioids for sleep, anxiety, or emotional distress rather than pain. Opioid use disorder is different. It involves a problematic pattern of opioid use with impaired control and continued use, risky use, despite harm, craving, or significant impairment. Now, I'm kind of repeating all of these concepts because these are extremely important for you to determine and make that distinction, because this distinction protects patients. And if we overdiagnose OUD, we are stigmatizing patients who may be dependent but not disordered or not having OUD. And if we underdiagnose OUD, we miss a treatable condition that can increase overdose risk and destabilize care. So the professional approach is discipline. Do not minimize, do not dramatize, but assess, document, diagnose when appropriate, and treatment and treat the OUD. Red flags should not be used as automatic proof of OUD. They are signals. There are signals that the provider should reassess risk, update the diagnosis, and consider a higher level of structure. A red flag is not automatically a diagnosis, say a clinical diagnosis of OUD, but it is a signal that the provider needs to reassess. A missed appointment, for example, could reflect transportation barriers. An early refill request could reflect uncontrolled pain, misunderstanding, withdrawal, misuse, diversion, or loss of medication. An unexpected urine drug test could reflect undisclosed exposure, assay limitations, metabolism, cross-reactivity, or true non-adherence. So red flags require interpretation at a much deeper level. They should trigger clinical evaluation and not automatic punishment. But when red flags accumulate, concern increases. And when concern increases, the treatment plan must be reassessed. The worst response is autopilot. A refill should not continue simply because it has always continued. Like fill the prescription just because it was filled in the past. Common red flags include repeated early refill requests, repeated reports of lost or stolen prescriptions, dose escalation without meaningful functional improvement, or even without proper imaging, multiple prescribers or multiple pharmacies on PDMP review, unexpected toxicology results, concurrent opioid use with benzodiazepines, alcohols, or other sedatives, sedation, confusion, near falls, or respiratory risk, missed appointments paired with urgent refill requests, strong resistance to monitoring, deteriorating function despite increasing opioid exposure, withdrawal symptoms between doses, craving or preoccupation with the medication, taking more than prescribed, using opioids for anxiety, sleep, stress, emotional distress, and other behaviors, and continued use despite medical, occupational, legal, family, or safety consequences. And again, these are not automatic diagnoses, but they are not background noise either, but they are clinical signals. When red flags appear, ask yourself, is this uncontrolled pain? Is this undertreated anxiety or depression? Or is this poor sleep? Is this opioid-induced hyperalgesia? Is this tolerance? Is this withdrawal-driven use? Is this unsafe co-use? Is this diversion? Is this emerging opioid use disorder? So there's multiple questions you need to ask yourself like this. Now that is the provider mindset, and that's the kind of mindset we need to have, but not accusation, not denial, not a differential diagnosis. Because in pain management, the danger is not only prescribing opioids, the danger is continuing opioids without understanding what the clinical trajectory is telling you. Opioid stewardship is not just about dose, it is about trajectory. If pain scores, for example, remain high, function remains poor, dose keeps increasing, and side effects are accumulating, and concerning behaviors are emerging, that is not a successful opioid plan. Even if the patient is suffering, even if the patient is frustrated, even if the patient is asking for more medication, now that trajectory should trigger reassessment. A poor trajectory does not automatically mean OUD or opioid use disorder, but it does mean the current plan is not working well enough to justify continuing without change. So providers need to recognize that moment pretty early on during treatment, before the patient is even harmed, before even you lose trust with the patient, before overdose risk increases, and before therapeutic drift becomes the default. Now, let's talk about the conversation. When opioid use disorder is possible, communication really matters. Now, a poor approach sounds accusatory. You like making an accusation. A professional approach is direct, calm, and non-judgmental. Now, you might say, I want to talk through something important. I'm seeing patterns that raise concern about safety with the current opioid plan. Now, this does not mean I'm judging you, and it does not mean I'm abandoning you or discharging you. It means we need to reassess whether this treatment is still helping and whether opioid use may be creating harm. Now, that language does three things. It names the concern, it preserves dignity, and keeps the patient in care. Patients would love to trust you. Another useful phrase is, my responsibility is to treat pain and also monitor for harm. When the risk picture changes, the treatment plan has to change too. Now, that is firm, that is fair, that is professional, and you maintain and continue to build patient trust. So document the behaviors, not moral judgments if OUD is suspected. Documentation should be specific. Avoid vague labels like drug seeking, non-compliant, manipulative. These terms are often imprecise and stigmatizing. Instead, document observable behaviors. For example, 3 early refill requests in 2 months. PDMP shows opioid prescriptions from 2 outside clinicians. Patient reports taking more than prescribed. Urine drug testing shows unexpected non-prescribed benzodiazepine. Patient reports withdrawal symptoms when medication runs out early. Function has declined despite dose escalation. Patient continues opioid use despite sedation and near falls. Now, that kind of documentation supports clinical reasoning, and it also supports safer patient care. A strong note shows what was observed, how it was interpreted, and what plan was eventually followed. And a weak note only labels the patient, stigmatizes the patient. Now, when evaluating for opioid use disorder, assess for impaired control. Is the patient taking more opioids than intended? Have they tried unsuccessfully to cut it down? Is there any craving associated with opioid intake? Is there excessive time spent obtaining, using, or recovering from opioids? Assess also for social and functional impairment. Is opioid use interfering with work, family responsibilities, or even daily function? Assess risky use. Is the patient using opioids in dangerous situations, combining with sedatives, continuing use despite respiratory risk, sedation, or even falls? Assess for continued use despite harm. Is the patient aware of the harm but unable to stop or reduce? Now, the full pattern, the big picture, the whole picture matters. Not one event or not one lab, not one difficult visit. It's the whole pattern. Are we seeing a big pattern in the patient? Now, when opioid use disorder is identified, the response should be treatment and certainly not abandonment. Do not abandon your patients for these kind of behaviors or opioid use disorder as much as possible. CDC guidelines emphasizes arranging evidence-based treatment when OUD is present, and SAMHSA describes FDA-approved medications as central treatment options for OUD. Now, that does not mean continuing the same opioid regimen unchanged. It does not mean ignoring unsafe behavior. And it certainly does not mean removing boundaries. It means the response should be structured. Assess the diagnosis. Assess immediate safety. Discuss the concern. Offer or arrange for treatment. And address overdose prevention. Very important. Coordinate care and document the plan comprehensively. Now, a patient with OUD should not be discharged into risk. They should be connected to treatment. Now, many clinicians still use the phrase medication-assisted treatment, as I mentioned before, or MAT. Increasingly, many organizations prefer medications for opioid use disorder or MOUD, and that's what we prefer now. Now, that language matters because the medication is not merely assisting treatment. It is also evidence-based treatment. The FDA-approved medications for OUD include buprenorphine, methadone, and naltrexone as reviewed in SAMHSA Tip 63. Now, these medications are not replacing one addiction with another. That phrase is inaccurate and certainly stigmatizing. Now, these medications can reduce withdrawal, reduce craving, stabilize opioid use disorder, improve retention in treatment, and reduce overdose risk. For pain clinicians, understanding MOUD is no longer optional. It is part of modern opioid stewardship. So if you're looking into going into pain management, please educate yourself about all these concepts. Now, MOUD includes three main medication options. Like I mentioned, buprenorphine, methadone, and naltrexone. Buprenorphine is a partial opioid agonist and can be used in office-based or specialty care. Methadone is a full opioid agonist provided through certified opioid treatment programs for OUD. Naltrexone is an opioid antagonist used after an opioid-free period. Now, let's briefly review the medication framework. How do they work? Now, buprenorphine, like I mentioned, is a partial opioid agonist used for OUD treatment, and depending on formulation and clinical context, may also have analgesic relevance. Buprenorphine works great for chronic pain as well. Methadone is a full opioid agonist used for OUD treatment through certified opioid treatment programs like I mentioned. It's an opioid antagonist option, but patients must be opioid free before initiation, which can be a barrier. Now, the choice depends on patient factors, clinical setting, regulatory context, access, safety, treatment history, and patient preference. Now, for providers in pain management, the key is not that every clinician must personally deliver every OUD service. No, the key is that every clinician who prescribes opioids should know how to identify OUD and connect the patient to appropriate treatment. Buprenorphine, like I said, is a partial mu opioid receptor agonist, and it's one of my most favorite medications for OUD. For providers, that means it can reduce withdrawal and cravings while offering a safer pharmacologic profile than full opioid agonists in many patients. It is one of the core evidence-based medications used to treat opioid disorder. What are the clinical benefits? It reduces withdrawal, it reduces cravings, it treats OUD, it may support safer pain strategy in selected patients, it may also lower respiratory depression risk than full agonists, but not risk-free. Buprenorphine is particularly important because it can be relevant both for OUD and pain. A professional way to introduce buprenorphine is based on what you're describing: withdrawal, cravings, difficulty controlling opioid use, and safety concerns. I'm concerned that opioids are no longer functioning only as pain treatment. That's the way you can talk to the patient. And you can mention that buprenorphine is an evidence-based medication that can treat opioid use disorder and help us create a safer plan. I found buprenorphine to be extremely useful for chronic pain as well. Now, methadone is a full opioid agonist and an effective treatment for opioid use disorder. It may be especially useful for patients with high opioid tolerance or when buprenorphine is insufficient. For OUD, it is generally provided through certified opioid treatment programs, so pain providers should know their local OTP referral pathways before a crisis occurs. Effective, what are the key points? It's effective for OUD, it may be appropriate for high opioid tolerance, and it's often useful when buprenorphine alone is insufficient. And for OUD, treatment is generally through certified OTPs. And it requires careful monitoring, including respiratory and cardiac risk factors. Pain providers should know their local OTP referral pathways before the crisis occurs. Extended release naltrexone is an opioid antagonist. It blocks opioid receptors rather than activating them. So the patient must be opioid free before starting to avoid precipitated withdrawal. For selected patients, it can be effective relapse prevention option, especially when they prefer a non-agonist medication approach. The important considerations for this should be the patient must be opioid free before initiation and can precipitate withdrawal if opioids remain present. And it may fit selected motivated patients. And it requires relapse prevention training. Naltrexone may be a good fit for patients who strongly prefer antagonist treatment, have completed detoxification, have a stable environment, or have occupational or personal reasons to avoid agonist treatment. Naloxone saves lives. It can reverse opioid overdose by helping restore breathing, and it should be offered to patients at elevated risk. In fact, there are laws in place where you have to prescribe naloxone. It also includes patients with OUD, prior overdose, higher opioid exposure, sedative, co-use, or fentanyl risk. Prescribing naloxone is not judgment, it is basic overdose prevention strategy. And offer it whenever OUD is suspected or diagnosed, prior overdose, higher opioid doses, opioid plus benzodiazepine use, respiratory disease, or sleep apnea. Whenever there is illicit opioid or fentanyl exposure, or whenever there's a household overdose risk. Medicare LCD L39849 addresses coverage for opioid treatment programs, and it describes OTP treatment as reasonable and necessary when the beneficiary is diagnosed with OUD using DSM criteria and voluntarily chooses maintenance treatment and is currently addicted to an opioid drug. The LCD also outlines an initial assessment that includes confirmation of OUD diagnosis, medical history, psychiatric screening, relevant laboratory testing, informed consent, treatment planning, assessment of withdrawal potential, overdose prevention, education, and offering take-home naloxone. For physicians, nurse practitioners, and physician assistants, the practical takeaway is this: OUD treatment is not simply writing a medication order. It requires assessment, informed consent, treatment planning, safety planning, psychosocial needs review, drug testing review, and documentation. And that is the professional standard. Medicare LCD L39849 also recognizes that care in certified OTPs may involve multiple covered provider types, including physicians, nurse practitioners, physician assistants, clinical psychologists, licensed clinical social workers, clinical nurse specialists, and other licensed mental health providers as authorized by respective state laws. Now that matters because OUD treatment is a team-based care. Pain clinicians should not operate in isolation. If OUD is identified, treatment may involve addiction medicine, primary care, behavioral health, counseling, peer support, pharmacy coordination, and sometimes an opioid therapy treatment program. So the provider's role is to identify the concern, stabilize the safety, and connect the patient to right level of care. Another important principle from Medicare LCD, Local Coverage Determination L39849, is that use of other addictive drugs should not automatically be a reason to withhold or suspend OUD treatment. Patients actively using substances may require greater support or a more intensive level of care, but treatment should not be reflexively denied. Now, this is clinically important. If a patient with OUD also uses benzodiazepines or alcohol, stimulants, or fentanyl that increases risk, but the provider should be more careful with the treatment and certainly not include abandonment in the overall approach to patient care. Higher risk should lead to higher structure, more monitoring, overdose prevention, naloxone use, care coordination, and appropriate level of care. Providers do not have to navigate this alone. PCSS MOUD is a SAMHSA-funded national training, guidance, and mentoring program designed to help healthcare professionals identify and treat opioid use disorder using evidence-based medication treatment. Now, this is important for physicians, nurse practitioners, and PAs who may feel comfortable with pain management but less comfortable with OUD treatment. Now, the solution is not avoidance. The solution is training, mentorship, and building reliable referral and treatment pathways. Every opioid prescribing practice should know its OUD response pathway before crisis appears. Now, let's apply this clinically. A patient, for instance, has chronic lumbar pain and has been on opioid therapy for several years. The dose has increased over time. Pain remains 8 out of 10. Function is declining. Patient is requesting early refills twice in 3 months. PDMP, prescription drug monitoring program, shows an outside opioid prescription after a dental procedure that was not reported. Urine drug testing shows the prescribed opioid, but also a non-prescribed benzodiazepine. The patient reports sedation and poor sleep. What should the provider do in such an instance? And it's certainly not autopilot, not immediate dismissal, not reflex dose escalation, because the patient says that the pain is 8 out of 10. This patient needs a structured reassessment. Review PDMP, prescription drug monitoring program, clarify the outside prescription, interpret toxicology carefully, assess sedation and respiratory risk, screen for OUD criteria, discuss naloxone, assess whether continued opioid therapy is helping or harming, and if OUD criteria are met, offer or arrange evidence-based treatment. Now that is opioid stewardship, and that would establish a very healthy patient-doctor relationship. But do not ignore red flags because the patient is likable. Do not overreact because the patient is difficult. Do not use urine drug testing as a trap to catch patients. Do not diagnose OUD from one unexpected result alone. Do not dismiss patient without treatment planning or providing a comprehensive treatment for the patient. Do not abruptly stop opioids without considering withdrawal and safety. And do not confuse dependence with addiction. Do not continue escalating opioids when function is not improving and harms are accumulating. Do not document vague moral judgments. And certainly do not assume that referral alone is going to solve the problem. Instead, assess, clarify, diagnose, treat, coordinate, monitor for risks and harms. When OUD is suspected, ask yourself, what specific findings raised concern? Have I assessed pain and function? Have I reviewed PDMP data, prescription drug monitoring program data? Have I interpreted toxicology carefully? Have I assessed sedative co-use? Have I evaluated mental health and suicide risk? Have I asked about withdrawal, craving, loss of control, and use despite harm? Have I discussed the concern directly with the patient? Have I considered MAT or MOUD? Have I offered naloxone when risk is elevated? Have I arranged follow-up or referral? Have I documented the clinical reasoning behind your opioid management? Now that checklist turns a difficult situation into a clinical process. And that is what providers need. A process, not panic, not avoidance, but a process. Now, here's a practical framework you can use in clinic. Now, I call it the SAFE OUD or Opioid Use Disorder Framework. The SAFE Opioid Use Disorder Framework gives providers a simple structure: safety first, ask directly and non-judgmentally, fit the pattern to DSM criteria, and engage in treatment, not abandonment. Now, this approach keeps the visit focused on risk reduction, accurate diagnosis, and evidence-based care. Buprenorphine, methadone, and naltrexone are medical treatments and certainly not moral judgments. Now, when we present MOUD this way, we reduce stigma, improve trust, and help patients access evidence-based care for opioid use disorder. For physicians, nurse practitioners, and physician assistants, the goal is not to police pain patients. The goal is to practice high-quality, evidence-based, compassionate, and defensible medicine. So as we close, remember these principles. First, red flags are signals and not verdicts. Second, opioid use disorder is a clinical diagnosis and it's not a moral failure. And third, MAT or MOUD is evidence-based treatment and it's not a last resort. And fourth, the provider's response should protect safety while preserving care. Now, that is how pain clinicians bridge the gap between pain expectations and medical reality, and not by ignoring risk, not by abandoning patients, as I kept saying during the presentation, but by practicing disciplined, compassionate, evidence-based opioid stewardship. So friends, in our next series, we move into the third pillar, exciting, healthcare administration and compliance. Now, this is where clinical care meets Centers for Medicare and Medicare rules, documentation, billing, coding, and payer scrutiny. We'll begin with CMS guidelines in billing and coding and how pain providers can better understand medical necessity, compliance risk, and defensible documentation. So this is Pain Policy Practice, where we address the system to improve the experience. And we will definitely keep these conversations practical, evidence-based, and clear. Goodbye.